Hey, my name is Colleen and I'm a doctoral nursing student at the University of South Alabama, and I'm here to talk to you about my quality improvement project entitled Improving Bone Health using a nurse-driven fracture liaison service model of care. Osteoporosis happens when your body loses too much bone, it makes too little bone, or both of these happen simultaneously. Risk factors for osteoporosis development include increasing age, female gender, family history of osteoporosis, consumption of a diet low in calcium and vitamin D, low estrogen or testosterone levels, and the presence of certain chronic diseases like kidney disease or rheumatoid arthritis. The long-term use of steroids or acid reflux medications can also contribute to osteoporosis development. The incidence and prevalence of osteoporosis is expected to increase as the population ages. The elderly population is rapidly increasing in size, with the number of individuals that are living past 60 years of age increasing worldwide. The World Health Organization estimates that by 2020, approximately 22% of the world's population will be over the age of 60. That's double the rate from 2015. Osteoporosis is usually diagnosed with a bone mineral density scan or by the presence or history of a fragility fracture. And osteoporosis is the primary cause of fragility fractures. And by fragility fracture, I mean a broken bone that results from a low or a no impact fall. And again, osteoporosis is the primary cause of fragility fractures, but in practice, patients are not being worked up or screened for any underlying osteoporosis. They're coming in with the fall and the broken bone. They're being treated for the bone, but their osteoporosis is not being identified and treated as well. And that puts them at increased risk for secondary fracture and resultant increased costs of care treating that secondary fracture, diminished quality of life, and increased morbidity and mortality rates. Implementation of a fracture liaison service model of care results in the early identification and treatment of osteoporosis. And this results in reduced secondary fracture rates, improved treatment initiation and compliance, and improved quality of life. So fracture liaison service is a secondary prevention program. The traditional model for a fracture liaison service consists of a physician champion, which is usually an orthopedic surgeon, and then you have your nurse navigator. And the goal of the nurse navigator is to really get the patients into the fracture liaison clinic. So they are identifying the patients through community screenings, primary care clinic visits or affiliations, and then they're also in the hospital identifying the fracture patients through billing coding software. Once you have that nurse navigator, they're pulling these patients into the fracture liaison service clinic. And so the clinic is usually run by a mid-level provider, so some sort of nurse practitioner or a physician's assistant. And that person is responsible for the investigation and identification of any underlying osteoporosis. So they're ordering the bone mineral density scans, they're reviewing all of the lab work, and then they're taking that and developing an individualized treatment plan and following this patient throughout the course of their disease. The clinic that I was working at is a large orthopedic surgery practice in southern Alabama, and they had recently established a fracture liaison clinic. So the orthopedic practice began using a 5-question bone health questionnaire, and this is something that they had developed to identify patients at high risk for having unidentified osteoporosis. And so the screening questionnaire was administered to all new patients over the age of 50. A review of the electronic medical record revealed that this screening was conducted appropriately for about 2/3 of the new incoming patients. And over half of those who were screened needed further investigation for the presence of osteoporosis, so that they needed a referral to the fracture liaison service. However, that referral was only generated about 2% of the time. And this was important because that fracture liaison clinic was operating at a volume that failed to allow for clinic sustainability. And you still had a great deal of these patients going untreated. The fracture liaison clinic that was in existence within that orthopedic group lacked a nurse navigator. And remember that nurse navigator's job is to generate that referral. They were relying on the surgeons and the physicians to look at that screening tool, initiate a conversation with the patient, and then generate that referral to the fracture liaison service. And as you can see, this was not happening. So that led to the development of the Quality Improvement Project. So the Quality Improvement Project aimed to provide a comprehensive bone health care for the prevention of osteoporosis-related fragility fractures. Our goals were to increase the fracture liaison service clinic referral rates, and this was strictly looking at in-house orthopedic clinic referrals. We wanted to improve patient knowledge on osteoporosis, improve patient fear of falling after they've been to the fracture liaison service, which indirectly ties into quality of life. And then we wanted to increase the fracture liaison service clinic patients' vitamin D levels because vitamin D has an important role in bone health. And if we can demonstrate increased vitamin D levels, then we can postulate that their bones are stronger and healthier. This slide outlines the beginning of the quality improvement process. So after we got IRB approval, the next step was to validate the bone health screening questionnaire that was being used. And so we validated this using a Lawshe method. So content validity index for this 5-question bone health questionnaire was 0.696, which is kind of marginal. There were 2 questions on the questionnaire that content experts felt weren't necessarily essential for inclusion, and they related to the presence of a past gastric bypass surgery or banding surgery. And then another question asked if someone had ever told them that they needed to take osteoporosis medications before. Experts felt that these were 2 questions that didn't necessarily needed to be included to identify the patients who were at high risk, but the fracture liaison service practitioner did feel that they were important to this particular population because the long-term effects of gastric banding and gastric bypass surgeries really hasn't been examined thoroughly on bone health, and there's a high degree of non-compliance with osteoporosis medications. So those questions were kept in. If we had removed those 2 questions, our content validity for that screening questionnaire jumped up to 0.91. So patients who were new to the overall orthopedic practice, who were greater than the age of 50 or equal to the age of 50, who were arriving for their initial orthopedic appointment were screened with this 5-question questionnaire. If they had any yes on any of those 5 questions, they were deemed to be at high risk, meaning that we needed to get a little bit more information to them. They were someone who needed to be referred on. So what we had the nurse in the clinic do, and remember this is just the orthopedic clinic, the nurse in the orthopedic clinic would go in, see that patient, and give them a brochure about the Fracture Liaison Service Clinic and provide a brief education about osteoporosis. And this was all contained within that brochure, and this was something that we had developed in conjunction with the Fracture Liaison Service Clinic. The nurse, the orthopedic clinic nurse, would then notify the surgeon or healthcare provider that, hey, this patient is someone that you really might need to refer to the fracture liaison service. I'm concerned about their bone health. And the idea was the surgeons would generate that referral and carry the patient through. If they did not answer yes to any of these questions, they were considered to be at low risk for the potential of an underlying osteoporosis, and no education was given, no visit by the orthopedic clinic nurse was needed. In order to assess the efficacy of the fracture liaison service, we examined patient knowledge and fear of falling were our primary outcomes. So we used the osteoporosis knowledge assessment tool, and this is a 20-question tool that looks at patient understanding of osteoporosis, risk factors, lifestyle modification and prevention techniques associated with osteoporosis, and then treatment plan options as well. So patients are given these 20 questions and they answer true, false, or they don't know the answer. And a higher score correlates with an increased knowledge. And so when patients first presented to the fracture liaison clinic, they were given the OCAT, is what we called it. So they were given a pre-OCAT. The clinic nurse practitioner would go in and educate the patient about osteoporosis, treatment options, draw some labs, and then talk with them about a potential plan for their management. After all of this was done, which usually took about 30 minutes or so, I would go back in and administer our post-OCAT. The falls efficiency scale is a 16-question tool, and that examines the patient fear of falling when they are performing routine daily activities. So these are things like how scared of you of falling, or how concerned are you about falling when you're cleaning the house or getting in and out of a chair, going to visit a friend, or going to the shopping center. And participants rated this concern on a 1 to 4 Likert scale, where 1 was no concern and 4 was very concerned. And this was given to the patients on their initial clinic visit to the fracture liaison service, and then at 3 months follow-up as well. The OCAT was paired because the pre and post OCAT were given on the initial clinic visit, but because we weren't collecting sensitive patient identifying information, the falls efficiency scale was not a paired study. So this was administered at their first clinic appointment, and then anyone who was coming in for a 3-month follow-up visit was given the opportunity to participate in this survey as well. Our initial plan was to look at vitamin D levels. About 50% of women who have bone loss have inadequate vitamin D levels. When we actually were drawing the vitamin D levels on their initial fracture liaison service clinic, everyone who agreed to participate in our quality improvement project actually had normal vitamin D levels. So their baseline levels were normal. We didn't draw a 3-month follow-up lab on those patients. So that was kind of disappointing. We weren't able to capture that. Observationally, this was not very common. So the patients that we were pulling into our quality improvement project data collection were not always your typical clinic patient. We did our statistics once we collected all of our data, and I've kind of mentioned this a little bit before. Our OCAT results, so that knowledge results, we did a paired students t-test. The clinic referral rates and the falls efficacy scale, they were non-paired t-tests, and the vitamin D levels, had we been able to collect that 3-month follow-up, those would have been analyzed using a non-paired t-test as well. We ran the statistical analyses, but unfortunately our samples were too small to really truly say that we had statistical significance. But I'm still going to report some of our data here just to give you an idea of where the data might be heading had we had a larger sample. This is Sarah. She is the fracture liaison service nurse practitioner, and so she's smiling because our nurse-driven intervention did improve the clinic, the fracture liaison clinic referral rates. We had an increase of 37.9% in our in-house referrals, and by in-house referrals, I mean those are the referrals from the larger orthopedic practice that this fracture liaison service operated underneath. So we went from 2.9 patients per clinic day in the beginning, pre-intervention phase, to 4 patients per clinic day who are being referred in the post-intervention phase. But again, our p-value is still pretty high, so we can't say that this is truly a significant finding because of our low sample size, but we are seeing an increase, which is supported in the literature. Clinic volume increased from 16.4 patients per week to 18.5 patients per week. And again, our p-value is still high, and we can't say it's statistically significant because of our small sample size, but we're trending in the direction that literature suggests that we should be trending into. This may not have had an ability to be declared statistically significant or anything like that, but it was financially significant because the clinic needed to demonstrate 18 patients per week to show that they were sustainable. They were financially independent on the most basic lowest level of patient care. And this intervention allowed the clinic to reach that volume load. And it also was clinically significant because it means the patients are getting the help that they need. OCAT results, we did see an improved overall gain in knowledge. This was most obvious related to risk factors. Not only can the knowledge gains benefit the patient, but it can also benefit those family members and friends who are taking the patients to the fracture liaison service appointment. Remember, a lot of these are coming in with a broken bone, a broken hip, spine, wrist, rib, something like that. And so they typically have someone with them to help them out. So that was important to us. We did, again, if we were able to declare these statistically significant, these were our strongest competitors and our strongest gain here. I turned this slide kind of like my delta change slide. Our delta, our biggest change, our best knowledge gain was related to just basic knowledge of osteoporosis. So patients had good knowledge retention of what we were telling them about some of the important things. And by good knowledge retention, I looked at anything that had on that OCAT, that 20-question OCAT, anything that had a score almost at 2, because 2 is the highest score that you could get. And that means that they were getting these right consistently. So patients understood what osteoporosis was. They understood that it led to bone fractures, and they understood that there are multiple things that can contribute to the fracture. So the bone strength, and then you've got to have that, that fall as well. Family history of osteoporosis predisposes a person to osteoporosis, and then patients were able to identify some good dietary sources of calcium, and so that was good. You know, hopefully that this would translate into their lifestyle modifications. Areas that we needed to work on in our clinic education, meaning that these patients were exhibiting a declining score, these questions were. So their pre-score was actually better than their post-score. We needed to do a better job clarifying about taking good care of your bones when you're at a young age. So implementing these lifestyle changes early on so that you do have a peak bone mass to kind of guide you into your later life. You know, you're getting them up as strong as you can when you're still building that bone mass. And then talking to them about cigarette smoking. Hopefully they're not smoking cigarettes, but if they are, they need to understand that this has a negative impact on osteoporosis development and can further worsen their case if they're still doing this. Our falls efficacy scale showed us that patients actually were a little bit more scared of falling at the 3-month mark versus their initial incoming visit. And that was a little bit surprising to me because in my mind, I felt like as they learned a little bit more about their disease and that they felt like they had a really good plan to tackle this, they would feel more confident in their ability to carry out their activities of daily living without fear of breaking another bone. This score kind of shattered that reality. It wasn't statistically significant by any means, but it was still showing a trend towards an increasing fear. And so I looked into literature a little bit more, and I kind of looked at it from a different angle than how I looked at it before. I think I went in before with these preconceived notions, and that clouded my view of the literature that I was really looking for. And I did find a few studies that supported the idea that at about that 3-month mark, patients may have a little bit more fear than they did initially because they know more. They've had a fracture, they see how it impacts their life, and they're scared of having another one. Even though they've got a plan for it and it's under control, they still fear this ongoing debilitation that they've experienced from this original fragility fracture. So, a future recommendation related to that would be a longitudinal examination of fear falling. The Fracture Liaison Clinic did establish treatment care plans for these patients. So there are a couple of pharmaceutical choices for these patients. The main drug classes are drugs that can help slow bone loss, and then you also have another drug class that can actually stimulate bone growth. And so it would be interesting to see longitudinally, is there a link between fear of falling and the classification of the drug that the patient's on? And does that conversion from an initial fear, an increasing fear, to more of a stable, I feel more confident that I can go back to my daily living because I feel like my treatment is working. When does that occur? When does that fear of falling start dipping back down? Is it related to the pharmaceutical agent that the patient chooses? But our data did suggest, even though our small sample size limited us in the ability to say it's statistically significant, our data did support the idea that having a nurse-driven protocol is something that should be considered for the fracture liaison service who cannot afford a nurse navigator. That's a luxury that not everybody's able to have, and if we can get the staff nurse activated in this process, then we can still reach these patients and provide them with the better care. Some of the other things that we're looking at in the future are expanding the idea of this nurse-driven protocol into an inpatient setting. So a lot of these patients are coming to us from the hospital. So if we can tackle them, or not tackle them per se, but if we can get a hold of them before they're coming to their follow-up surgical appointments in the outpatient setting, then we can get this process initiated even earlier. We can get them on the medications that they need and hopefully get them to the fracture liaison service with an already improved baseline knowledge to help implement some of these lifestyle changes that they would need. One of the other limitations that I really noticed in this quality improvement adventure was the importance of a stable clinic. So during the quality improvement implementation time, the overall orthopedic practice underwent several leadership changes related to the nursing staff. So you would get staff on board, you would have great communication efforts, they would get very motivated, excited, and I would see, I'd be running out of brochures, and then you would have a drastic change in leadership, and things would kind of fall off. Communication levels would drop, motivation would decrease because they're dissatisfied with the clinic environment and their job as a whole. So that brought in kind of a challenge in some areas. The actual fracture liaison clinic also experienced some instability as well. There was a nurse who worked in the clinic, but she worked strictly in the clinic. She was not in a nurse navigator role. She was simply a nurse who would, collect basic demographic information, insurance, do the billing, coding, and then collect the blood for analysis as well. But she went out on medical leave, and so there were a couple of times where different nurses would rotate and different medical assistants would rotate in and out of the clinic, the fracture liaison service clinic, and they weren't very familiar with the process or with some of the education that was needed to be given to the patient. And so that was a limitation there as well. But overall, the data suggests that a nurse-driven protocol, whether even in the midst of all these limitations, can still have a positive impact on identification of osteoporosis and getting those patients into an environment where they can be treated and managed to help prevent that secondary fracture and improve their quality of life. And I hope this is something that you will consider as you continue to see patients and visit with your older adults and families and loved ones as well. If you have any questions, please feel free to contact me, and it's been a pleasure talking to you. Thanks.